Thank you, Dr. Joe. We've certainly covered a lot of information today, some of it technical, and that was very interesting. We'll open up this time now for questions, and if people would like to raise a hand in the question area of the attendee area, if they would do so, we can call on you and unmute your line. Alternatively, if you want to put type a question into the question box, that will work as well.
Hello, Kim.
Yes, Michael. Hi, go ahead.
Hi, it's Michael in Waterloo Region. Question for Dr. Joe. Is there an upper limit when administering naloxone to an overdose victim? Like twice is okay, or 4 times if necessary?
As far as our program is concerned, 2 vials are included in the kit. So the usual prescription would be to administration at the time of the incident as well as 5 minutes after. Now the intent of this is to understand that emergency health services would probably arrive after the 5 minutes. However, in certain overdose interventions, as I mentioned in the previous slide, and also the experience of hospital physicians, 20 times that is necessary in reversal of some opioids like buprenorphine or methadone. So there is no real upper limit, to answer your question.
Right, and then and the risks don't increase if it's necessary to administer 15 or 20 times, for example.
That's correct. In people who are not using opioids, for instance, if you actually happen to administer opioid naloxone to them, no harm would be done either way. That means whether they have opioids in the system or not.
Okay, thank you.
Thanks, Dr. Joe.
What?
Go ahead, Michael.
Sorry, I was just going to say a common response when we raise the naloxone issues locally is that, you know, if you provide naloxone to people, you will encourage riskier substance use. Is there any evidence of that in your practice?
There is no evidence of this in my practice, although no formal data has been collated yet. However, if we use U.S. data, it looks like the programs are being effective in reducing their overall death rates. And also from the San Francisco experience, most of the users were not actually calling 911. So as far as targeting the group is concerned, they were very successful in doing that by reducing their overdose deaths to 10. So really it depends on your target group. So there doesn't seem to be any preliminary evidence from our sites.
Yeah, that's what I understand as well. I mean, particularly if you're addicted to opioids or dependent, then withdrawal is what you want to avoid. And
the only circumstance to not potentially get into would be if you do the reversal so well as the individual gets acute withdrawal symptoms. And intuitively, the first thing they would want to do would be to use again. And so that could be quite a risky situation, and that is part of the education that we give to our participants who receive the kits.
Thank you. Any questions on your end, Kim?
Actually, I have a question, and it goes back to what you were saying, Dr. Joe, earlier about the need to inform and educate physicians about the availability of naloxone, its effectiveness, and how to prescribe appropriately. And I'm wondering, do you have any ideas about how we go about doing that, informing and educating, and essentially knowledge translation? Throughout this whole webinar series, there's so much information and some emerging practices that don't seem to be, it takes a while for them to get picked up. How do we expedite that?
Well, I'm working on that with our local college. So each of the respective colleges from each of the jurisdictions in Canada have a local college of physicians and surgeons, and they would have a prescriber program or monitoring program within each college. And they do provide circulars to physicians. So I think this is a good way of being able to articulate the benefits of this program. For instance, I'm part of the College of Physicians of BC's Methadone Maintenance Committee, which looks at this type of thing. And there is some work being done right now in being able to actually circulate this information to our physician membership at large. And also there would be need for media to be involved and webinars like this. I think it should be a multi-pronged approach.
Mm-hmm. Okay, thank you. All right, any other questions? I'm not seeing any hands raised at this point on my screen. I'm just double checking for any questions here. Just a quick comment, Dr. Joe. I was taken aback by how elegant your take-home naloxone assessment form is. Yes, very straightforward and easy to do, and obviously very evidence-based, and should be quite easy for physicians to use. So.
Yes, thanks for that. I spent some time before the initiative started, so we would be in a position to be able to collect data that's in a consistent format. Mm-hmm. Because we know that the evaluation of these programs is very important.
Yeah. All right, last call for questions.
Well, Michael again in Waterloo Region. You talked very quickly about co-prescribing naloxone with opioids currently. Is that something you're generally in favor of, Dr. Joe? I know it happens in different parts of the U.S. And good results out of North Carolina with co-prescribing.
That's correct. There are good results in North Carolina. Their program is unique in the sense that they've engaged physicians as part of the process as well, which other programs have not been so successful in. Of course, North Carolina has a much higher overdose rate per 100,000 of, from memory, around 60 or 70. It's terrible. So as far as co-prescribing is concerned, it really helps the client or the participant who is receiving the opioids really understand the severity or the nature of the drug that they're receiving. I think when there's a quick reflexive prescribing occurring, and that a conversation isn't necessarily involves the risks and benefits of opioids, I think that's certainly a bad thing. So I think it is good to actually spend time discussing risks and benefits, and part of it, if the risks are thought to be significant, that naloxone be prescribed. In some clients, from a personal experience perspective, they've been shocked by the fact that I've actually suggested they take naloxone, because they would then ask the question, then why am I taking the opioids? And then I think, well, perhaps, Dr. Joe, can you wean me off opioids if you think it's actually that dangerous? Can you put me on methadone? Can you put me on Suboxone? That's a common response.
Okay, Kathy has a question. Kathy, I'm going to open up your mic.
Hi, Kathy.
Oh, that's you. That's you.
Go ahead, Kathy.
I just hung up.
Oh. Okay, I'll read her question. Do you think there is any advantage for physicians who are prescribing opioids to also prescribe or to distribute a Narcan kit?
Absolutely. If you're not close to a public program, there's nothing precluding you from actually adding naloxone on a prescription. It comes in an ampule, so the You can personally do some training in providing a syringe for the client and also their family members, and also access some of the existing programs, training materials, and videos. So it is entirely possible. The only issue for your specific client may well be the fact that it's not covered by your provincial, usually by your provincial care plan. However, the cost is probably not prohibitive. Like, for instance, it is only approximately $12 per vial. So it is entirely possible, if you think that you're in a community that you're prescribing opioids to them and you're worried about an overdose.
Okay, thanks, Dr. Joe. Christine, are you seeing any other hands raised there?
No, I don't. I think that's it for now. Oh, wait a minute. Kathy has another one. Do you think physicians would do this? Could this be made mandatory through the CPSO?
Well, as far as the CPSO is concerned, they, I don't know the inner workings of the CPSO as far as how all the committees work, but I understand from the BC's perspective, we have a prescription review committee, and I think that they've been forthright in saying that people in Canada have the right to have their chronic pain treated. I think, on the other hand, it would not be a monumental leap to say that if there's judicious prescribing of opioids, we need to understand that certain high-risk groups that we're prescribing it to may be exposed to overdose risk, and that direction can be given from each of the respective colleges, because they've already given indication that we should be treating chronic pain.
Okay, thank you.
Kathy has another question. Is there any activity, advocacy going on for Narcan to be a med provided OTC?
The OTC environment is difficult in North America. I know in Italy it is OTC. Ideally, it as far as certain OTC medications are concerned, I would consider certain medications more dangerous than naloxone. So certainly the risks of having naloxone OTC would probably not be great. But I think certainly in the U.S., as far as their death rates are concerned, OTC should probably be provided. I think Canada, we're seeing signs of an opioid crisis. I think also it should be something that we should be considering, particularly when we have programs in certain pockets of the country, and it should be a countrywide initiative.
Thank you. Christine, are you seeing, I'm not seeing any other questions?
No other questions.
Okay. Well, I think I'll take this opportunity then to wrap it up and to give a heartfelt thank you to Dr. Joe. Thank you so much for sharing your professional expertise with us this afternoon. We really appreciate hearing about your recommendations and your ideas for advocating and engaging pharmacists and physicians in this issue. And we very much appreciate the time you've taken to share that with us today. So thank you, Dr. Joe. Now, I'll just sum up by saying that if anybody would like to watch a film, you can watch the new Eyes Wide Open short film on overdose prevention and intervention on YouTube, and you can find the link to that on our site at www.preventingcrime.ca. And I also want to say that we have an upcoming, sorry, my screen doesn't want to advance, but we have an upcoming webinar, which will be at the end of April, and we'll be hearing from one of the medical officers of health here in Kingston to learn about his ideas for a real-time monitoring system. So we look forward to that. So for a list of all the webinars and the recordings, please go to www.preventingcrime.ca. You'll find all of them there in the series, and we hope that you will share them with your colleagues and continue to spread the word. And we would welcome any and all feedback as to how to continue the momentum we've been able to generate with this series and other ideas for moving forward with this important issue. So I wish you all a great weekend. And again, thank you, Dr.
And Michael just has a few last words.
Oh, yes, please go right ahead.
Oh, sure, yeah, just fairly quickly for people on the line and people viewing after, there's been some recommendations at a more strategic level fairly recently. The Canada Centre on Substance Abuse released a prescription strategy called First Do No Harm in March, and the recommendation pertinent to this conversation we're having today is recommendation number 8. And one thing to know about the strategy is it is what it is. It's but it's really dependent on people across Canada and at the federal level, at provincial levels, and in community to get busy about implementing aspects of the strategy. But recommendation number 8, and they're proposing that Health Canada do it, is to review existing evidence or conduct objective research and make recommendations on the effectiveness, including the cost effectiveness of community-based prevention initiatives designed to reduce overdose and related deaths, and specifically mentioning take-home naloxone programs. So I want to make you aware that that recommendation does exist, and to which I would say look to the World Health Organization. The model medicine list includes naloxone on page 3 as the most efficacious, safe, and cost-effective medicine available to treat an opioid overdose. And I would also encourage people to look to some of the blue chip organizations in the U.S. like the Center for Disease Control, the American Medical Association, the American Public Health Association, the National Institute on Drug Abuse, the Office of National Drug Control Policy, etc. A lot of evidence to suggest that it works, and that's what we're seeing at national, state, and local levels in the U.S. The other recommendation for those in Ontario that would be pertinent comes out of the Stewardship for Narcotic Use in Ontario. It's called The Way Forward. It was convened in the wake of the OxyContin delisting here, and the recommendation there, we're now 3 months past due for its implementation, but is to increase naloxone provision via public health units in Ontario. So that report came out in October of last year, and it was due to be, the advice to the minister was to implement that within 3 months. So in different pockets of the country you'll see some of this stuff, but by and large it doesn't show up in strategy documents. I suggest to you, these people listening in on the webinar, that really you are the leaders in your community, and if we're going to wait around for a higher order authority to do something, then we may be waiting a very long time. In the meantime, that the tombstones will continue to rise. So hats off to Dr. Ron Joe and those in, throughout British Columbia really on the great work that's happening there to reduce the death rate, to reduce the injury rate. As a website, I would encourage people to check out Toward the Heart. It's the website from the British Columbia Centre for Disease Control. It's probably the best in Canada on aspects of naloxone for physicians, for those in enforcement, and for others. So without further ado, thank you so much, Dr. Ron Joe, for sharing your time with us across Canada, and all the best in your practice in Vancouver. Kim?
Thank you, Michael. And can I suggest, Michael, that we can get the links for the resources and the some of the advocacy efforts, and we can put those on the Eyes Wide Open site as well if people want to find out more and to take that leadership lead that you called for. So we'll get those from you. All right. Well, again, thank you. It's been a very informative hour that we spent together, and we urge you to share the links and the webinars with your colleagues. All right. Thank you. Have a great weekend, and goodbye for now.